Okay, everybody, we are going to kick off our first of two panel discussions. We are going to have joining us Dr. Peter McGuire, Dr. Georgianne Arnold, Dr. Mark Korson, Dr. Nicola Longo, Dr. Melanie Gillingham, and Mary Sowa, and we will be asking questions. So if you have questions you would like us to ask to the physicians panel, you can put them in the Q&A. And Stephanie Harry, are you back with us? Stephanie is going to be my co-moderator, and we're going to tag team asking all these great questions to our group. Welcome back, everybody.
Thank you.
How are you all doing? Good? So I've got a couple of questions that are specific for some of you, and the others are just general questions, so you can feel free to jump in and whatever feels right with you. Sound good?
Mm-hmm.
Okay. We're going to start off with Dr. Gillingham. Dr. Gillingham, can you speak to the increase in sudden cardiac arrest episodes among some of the long-chain disorders? Where are the clinicians at with their research? And do you think it's worthwhile to have a baseline of troponin labs so when a child is sick and in the hospital, they have something to compare it to?
Thanks, Kira. That's a good question. So I have been tracking an increased cases of some sudden death events in young adolescents, late adolescent, young adults with LCHAD. And at the moment, we've been working on chart reviews to try to find out what factors might correlate with these events. And Dr. Vinokur from yesterday is helping me work on looking at those very detailed electrophysiology of those things. And we're close to trying to get a publication out for that. So we're working on trying to identify some factors, but it's still really early in the research. We have a clinical trial in which we're recruiting subjects who have had an event versus those who have not, and putting them through some specific cardiac exams, a cardiac MRI, and some stress testing. And then I'm also pursuing it on a basic science level with some mouse and cell culture models to try to get at what might induce cardiac arrhythmias. So we're working on it, but it's still really early on in the process. A troponin or a BMP, that's a great idea, actually. I don't think it's routinely done when they're healthy, but I have just this week had an incidental finding of an extremely elevated troponin that we're pursuing. So having a baseline might be helpful. I think you're muted, Kira.
That mute has just been getting me all weekend. Okay, next question. When a child is in rhabdomyolysis, it was discussed that urine color is often brown or dark, but could it appear red in some cases? Anybody?
Yes.
Yes. The answer is yes.
Yes. Okay.
But don't rely on the color to guarantee that it's hemoglobin or myoglobin. You have to test for it.
Okay. So a discolored urine is cause for concern, regardless of the color, right?
Yes.
Steph, you have a question for us?
I do. This one was sent in as a lot of our kids are becoming young adults and thinking about drinking socially. Can you explain the implications of alcohol on a young adult with an FAOD versus the average person without a metabolic condition?
That's a
anyone in particular? Oh, go on.
yeah.
No, I'm just going to throw it out there. You guys can all weigh in and save us parents.
So I think this is a good question, and I've actually been asked a lot this question from some of the young adults that I have seen in various research studies. So I think the big thing with alcohol intake is that you want to not forget the key fundamental things like not fasting and eating plenty of calories. So if you're drinking too much that you're not really thinking about those other things, I think that's a problem. A little bit of alcohol intake is probably not going to have a huge impact, but just being smart about making sure you're watching your fasting times. Don't drink, go to bed and sleep for 15, 16 hours. So those kinds of things, I think, are the things that I've really emphasized, that they need to be responsible for their own health and not overindulge.
Yeah, alcohol impairs your ability to make glucose. And having an FAOD impairs your ability to make glucose. So you're drinking, you're not eating. If you overdrink, you may vomit. Then you may pass out and not eat for a long time. Is a glass of wine with dinner going to kill you? No, but an alcoholic binge has killed people with FAODs.
Great
Everyone
answer. Thank you.
Anyone else?
And I agree. I believe that, in regular amount, mean that the recommended limit, which is 1 glass of one drink for female and 2 drinks for males, no more than that in one day should be okay. The biggest issue is fasting. Some people who get drunk, they sleep for 18 hours in a row, and that it is a problem. So avoid excess, normal amount, it should be okay.
Okay, great. Thank you for that. And that's just not for our young adults who are trying to, understand a good balance, but for our adults as well. So can you talk a little bit about anesthesia? We've had lots of questions about anesthesia and which anesthesias should patients be concerned about with FAODs? Are there some that potentially could cause more concerns, like, for example, Novocaine with dental work?
I'm not aware of any issues with Novocaine. I know in the past there's been some concerns about propofol because propofol is a lipid-based anesthesia. However, we published a paper on propofol for use in for electroretinogram exams, and we calculated how much fat you get in a anesthetic with propofol, and it's very, very minimal. You eat much more fat than you would ever get from the anesthetic. And the thing I like about that anesthetic is that it's on and it's off, and you wake up and start drinking and eating much faster. So to my knowledge, basic anesthetics have not been problematic from the standpoint of providing too much fat, say with propofol. And the big thing is that once you wake up, you want them to start eating and drinking on their own as soon as possible.
Okay. Steph?
Actually, I would
agree. I think that
Go ahead.
giving calories during the time of fasting. So making sure that there is a plan for surgery for the administration of intravenous glucose. That is the important thing. When that is in place, you can do pretty much everything.
Yes, and just add to that yes, you want the patient to eat and drink after surgery. Never turn off the IV until they're doing so. So they're never in a dangerous situation.
Yeah, with people who don't have fatty acid oxidation, they wake up, they give them a sip of water, an ounce of water, a couple, if they drink it, they go home. And you need to stay around a little longer and make sure you really are going to keep that down and that you're really going to tolerate more than a few sips.
Yeah, absolutely. Stephanie?
The next question we have is, there's a lot of information shared with our families at clinical visits. What are a couple slices of information that you as experts feel are very important and that might be missed from the families? I know that's kind of a loaded question.
Could you repeat the question?
Sure. The question was is that families just get a lot of information at their biannual or annual clinical visits. And what is it that you feel that parents might be missing or not understanding the significance of as they leave your offices? Like, what's the key things we should always try to have in our back pocket?
I'll start by saying I think that's very individual. And I know one of the things that we try to do with our patients is seeing what their biggest concern was to them when they came in and just making sure that's been fully covered by the provider. And I'm sure every clinic does this, but we have a nice summary sheet for them that highlights the recommendations and just our contact information if there is issues, that they need to follow up on. But I think it can be very, very individual.
I think that's true. What you should never leave an appointment unless you understand everything that was told to you. Walking out and not understanding, you won't understand it better after you leave. I also think it's a good idea to always have a second person in the room, because when a lot of information is provided, it's good for two people to hear. You don't have one person doesn't hear everything, and it gives the opportunity to discuss it afterwards and confirm what you heard.
Okay, next question. When a child is on D10 in the hospital with rhabdomyolysis, is it common practice to suspend the use of MCT oil during this time? Dr. Longo and Dr. Korson, you're both shaking your head.
Well, I think that, the biggest issue is when somebody has a rhabdo and is in bad shape, many times they're not very hungry. You start feeding them, they start throwing up. So I think that, the management is giving calories and blocking catabolism. What I like to do, I like to give a lot of glucose and insulin. That it is really, something that speeds up muscle recovery. Insulin is one of the few things that help people doing better. The problem is to give insulin, you need to get hyperglycemia. That is why I like to give a lot of glucose. Once that happens and people start kind of waking up, and we have that, we are sure that the gut is functioning, MCT oil can be restarted. And, sometimes we even put down an NG tube. But the biggest issue is stopping the breakdown of the muscle. And insulin and glucose are the most effective way, in my experience, of doing it. The second thing, one needs to make sure that there are enough fluids. So sometimes we give other fluids as well to sustain, to prevent the deposition of myoglobin in the kidney and to shut down the kidney. So once we start seeing the creatinine and BUN improving, then we can do anything.
Okay.
I would use all available avenues to get calories in, but we would not want to get someone vomiting. So it depends a little on the clinical picture in each individual case.
Okay, the next question we
Anyone
have.
else?
Is there a
Scott?
particular nutrient that you have consistently seen your family struggle to get enough of? And how do you creatively add this back in?
So I'll take a stab at that. I would probably say calories. So looking at our patients in general, the ones that may not be doing very well, calories are the biggest thing that we struggle as a nutrient. And then, so it just depends on how old they are and different tactics that we're going to use, whether it's more formula or whether it's a polycal powder or whether it's getting smoothies in. But I would say just in nutrients as a whole, I worry about calories the most.
I would agree with Mary, but if the question is really dealing with micronutrients, I have not seen a lot of micronutrient deficiencies when patients are consuming 10 to 20% of their calories from fat. They get plenty of fat-soluble vitamins, essential fatty acids. It's a really strong restriction where I start to worry where fat is less than 10%, then you might see something. But as far as micronutrients, most of the, if you're eating a variety of foods and you're eating about 10 to 20% of your calories from fat, you're getting all of your micronutrients.
Okay. Dr. Korson, here's a question specific for you. The question is, how does a patient approach the conversation with their care team? that they want more extensive testing to look for metabolic abnormalities, right? Because we know in rare disease, it's usually the parents that are pushing for additional testing, and especially when patients don't have the luxury of having access to clinicians like we have here today. How do you broach those conversations?
So you mean speaking then to your non-metabolic physician that you want further testing? Is that what that's about?
Correct. Or you have a physician that's not as familiar with FAODs, right? And our parents then become the experts.
Well, I think if you have a good relationship with your doctor, then where did he or she will want to know where you got the information from, show the things that you were concerned about, and offer a solution, which is not to order more testing. I think most physicians will probably not feel comfortable about ordering tests about diseases they don't know about. But what they may feel more comfortable with is referring you to a doctor who does know about these conditions. So I would just, open up, say what your concerns are, show some information which kind of support those concerns, and discuss a possible referral.
Steph, you got a question?
I do. Dr. McGuire, this one was directed through when we had your discussion going. What are red flags that primary pediatricians should be looking for when a young child has reoccurring health system failures?
So I'm not sure I quite understand the question. Meaning red flags for
when should the primary pediatrician look to go beyond their expertise and bring in other immunologists?
Yeah, I'm assuming this refers to infection.
Yes.
Oh, okay, yeah. Because there's lots of red flags, right? Especially in pediatrics. So yeah, so with regards to infections, it's every kid gets infections, right? And as I showed in my talk and some of the data, up to about 3 years of age or so, you can expect anywhere between about 10 to 15 infections. So that's, about 5 or 6 a year, somewhere in that area. So red flags would be, a number of infections that kind of exceed, that number, excessive number of infections with unusual organisms. So in other words, if your pediatrician, if you have an infection or something, and it's either like if it's a line infection or whatever, and they wind up culturing the organism, they figure out what it is and they go, that's unusual. I've never heard of that one before. Or I don't normally see this in kids and stuff. That's something to think about as well. There are checklists for primary care providers with regards to, raising suspicion for immunodeficiency. So some providers will use that, which is based on number of infections like earaches and, upper respiratory tract infections and things like that. So I would say that it's frequency of infections, it's infections with unusual bugs. It's, thrush in the mouth, which doesn't resolve. I mean, there's a long list of things, but there are tools available for primary care pediatricians to screen for that essentially, and kind of set those are red flags essentially that would prompt a referral to an immunologist.
Thank you, Dr. McGuire. So we have another question come in about rhabdo in urine, and the question is it possible to have rhabdo without urine changing color? And are there potentially other causes other than rhabdo that parents should be aware of?
Other causes of
changes in urine color.
Oh, okay. Your CK has to, the amount of myoglobin you're putting in your urine has to reach a threshold before you can see the color change. So certainly milder cases of rhabdomyolysis don't necessarily have to have the color change. What are other things that can cause color changes in your urine? Beets can make your urine look red. Vitamins can give you a really dark, often yellow color with an odd smell, particularly if there's what is it, B2 in the vitamins? And so there are other things that can make your urine change color.
And also simply dehydration. If a person is not well hydrated, their urine can go a deep yellow or amber, and that can be mistaken as that kind of brown urine is really can be mistaken as an abnormal, but it's really just a hydration issue.
So we have a question coming in from the attendees. When should free amine be used instead of D10?
It depends on the purpose of what one is doing. So in general, if one wants to quickly reverse catabolism, again, the best way is to give a lot of glucose, and D10 is pretty much a D10 with the appropriate salt inside is the best way of getting there, that it is compatible with a peripheral IV. Sometimes we give higher value, but we need to place a line before giving higher concentration of glucose. So if one needs to start an IV just in case, then, pretty much anything is fine as long as some glucose is inside.
So a rookie question here, and maybe Mary, you can answer this. There's been lots of talk as we talk about nutrition and of the fasting. Can you talk about when we're talking about fasting, what does that mean in terms of FAOD, right? The average person thinks about fasting, right? You're not eating because you're trying to lose weight or whatever. But can you explain what fasting means when you talk about fasting?
So I know Dr. Arnold talked a little bit about this with her talk yesterday, so she'll definitely chime in there when I'm done. But I think when we think about fasting, we think about going longer in between a feeding interval than a normal person would. And so for long-chain fatty acid patients and even our MCAD patients, we want them to be doing a shorter time period. And certainly when they're sick, all bets are off and the fasting periods really need to change. But if we're just looking like in the infancy period, normal, healthy children can go 3, 4, 6 hours, can sleep through the night. But our long-chain fatty acid patients, we want to shorten that period. And that's going to vary clinic to clinic. So what might be normal in that fasting time is only allowing 3, maybe 4 hours during that time. We have some fasting guidelines on the VLCAD nutrition guideline protocols, and what we're suggesting is not longer than 10 hours of fasting for patients with severe fatty acid oxidation disorders after the age of 1, and not longer than 12 hours for patients with a mild or moderate form of the condition. So using those as kind of a baseline, and then that really needs to come down to the individual patient. Anybody else want to chime in there?
So really what fasting is, it's just the time between one meal and the next, right?
Yes, yes.
Just want to clarify that.
Thank you.
Absolutely. So we have a question about medium chain fatty acid oxidation disorders. There's lots of talk about, MCT oils being used for long chain fatty acid oxidation disorders. What are your recommendations for fat sources for those who have medium chain fatty acid oxidation disorders?
Well, until recently, basically there wasn't any. Long chain fat supplements will break down to medium, but then you're stuck with the medium chain intermediates. If someone was profoundly unable to metabolize any fat, you can, in theory, feed ketones. That's fairly new. Apparently, they don't taste very good, and they're not really widely routinely available at this point. But Dr. Broccoli has just presented some research that it turns out 7-carbon fats, so what we call triheptanoin, may actually be broken down by the short-chain enzyme. So it may be that we'll be hopefully starting soon some research on the ability to give 7-carbon fats to supply energy from fat for people with MCAD.
So, okay, so let me throw something out there. You have a patient who, your patients are eating, your MCAD patients are eating a heart-healthy diet, right? So that allows up to, 25% or so, plus or minus, calories from fat. Now you have, can those be medium chain triglycerides? Do they have to be long chain? Is there a problem with that? If you have a patient who is getting peripheral nutrition over a long period of time because of some, but it's otherwise stable, say recovering from surgery, stable, but it's going to be 2 weeks on TPN. Can you give, well, no, he's not on TPN, he's not going to get peripheral nutrition, but can you give that patient a certain amount of long chain intralipid to match what you might get in your ordinary diet? Is there a reason that's not okay?
I think it's okay. What do you think?
Yeah, I think it is absolutely okay. So actually, giving the proper amount of calorie is the best thing to do. So the way I say it is that in general, when people are eating, they utilize multiple enzymes at a much lower activity than the Vmax. Mean that, they have a little bit of activity from the VLCAD enzyme, a little bit from the MCAD, a little bit probably from other enzymes that we still do not know completely. And sometimes some other enzymes that, that are involved in other metabolic processes that might get rid of some fatty acid. As a result, if you are not fasting, when most of the calories do not derive from fat, you are perfectly fine. The problem is when you are fasting, when 80%, 90% of the calories are from fat. At that point, all of the enzymes are maxed out and are unable to deal with the metabolic demand. And for some reason, the MCAD enzyme is not disposable, but unless you really push it, you can get by. So it means that you extend probably the activity of the SCAD enzyme and downward the activity of the VLCAD enzyme in conditions that in which the body is not strong. So, but going back, if the child is getting intravenous nutrition, sometimes it is justified to give intralipid in minimal amount, maintain proper caloric intake, I think.
Thank you.
But going back to the question, is the question, what is a good source of fat in the diet for someone with MCAD? And for that, I would emphasize heart healthy, so lower fat, but healthy fats. So polyunsaturated fats, oils that are have omega-3 and omega-6 fatty acids, just an overall healthy fat source in a balanced diet with adequate calories.
Thank you for that. Steph, do you want to go?
Sure. This question was asked for Dr. McGuire. How concerned should we be with the Delta variant, even though our FAOD children are fully vaccinated?
Yeah, that's a great question. So while there's no data that really exists specifically for FAODs, in general, the vaccines that are currently available give good coverage against the Delta variant. So, while an individual, so what does that mean? So it means that individuals who are vaccinated still actually can get COVID, right? And still can get the Delta variant, but the rates of hospitalization, the rates of ICU admissions, et cetera, are are pretty much they protected against those particular scenarios, but they still may be able to get sick or have a milder form of illness. So it's really hard to say with regards to specific cases, but in general, the vaccine does prevent against those rather more severe adverse outcomes.
And then there was a follow-up question on that. Has anyone looked at using steroids to treat infections in FAOD children? That, I guess, can go to anybody.
Yeah. Yeah, I mean, so steroids in general, are in COVID. So I can speak specifically in COVID. Are the standards of treatments right now for COVID are essentially around steroids, because that's been the one thing that's been actually most effective, right? So they've tried things like, there are trials going on with ivermectin and various other drugs which haven't really panned out, and these are drugs that are supposedly aimed at the virus and part of the virus's replication cycle. But the one thing that actually has been effective with regards to this respiratory virus actually has been steroids. So, with regards to viral infections, and this is not new. I mean, this has been used for other viral infections as well as pandemic flu back in 2009. So, with regards to its utility in terms of viral infections, it is actually pretty effective with regards to respiratory viral infections that are on the severe end, like COVID and like, pandemic flu. So there have been, we are aware of patients who have fatty acid oxidation disorders, who have received steroids and for various reasons, including respiratory illness, and actually have tolerated them quite well. But that's, a limited experience.
Yeah, there's emerging evidence that in the long chain fat disorders, some of the problems associated with muscle disease and rhabdo are inflammation. So it may be that we'll be using a lot more steroids in some of those patients. On the other hand, would you treat someone with steroids instead of an antibiotic if they had a bacterial infection? Well, of course not.
No, these are also right. These are all supplements to, to therapies, to other therapies aimed at the organism itself.
I would just like to restate what Dr. McGuire just said. The vaccine is highly effective in preventing infection and even more effective in preventing morbidity and mortality. So keep in mind that, even though there are people who have been vaccinated, who have been infected with the Delta variant, only 2% or less of the death are due to people who have not been vaccinated, to people who have been vaccinated. So in other words, what that shows is not only reduce the chances of getting it, but also the chance of getting sick in case we get it. I do recommend vaccination for every patient who has a metabolic disorder. After saying this, I have patients becoming infected with fatty acid oxidation disorder and other conditions. Most of them have been relatively well. In other words, they have not required any specific therapy, most due to the fact that they are young. In general, the condition is less severe in young individuals. But again, the key to prevention is vaccine. There is no way around it if one doesn't want to prolong the pandemic for another couple of years.
Yeah, I would add 97% of the hospitalized patients were unvaccinated. About 0.5% of the recent deaths are unvaccinated. I'm sorry, 0.5% are unvaccinated. And unfortunately, this became a political football. And so there are people out there who are not masking and who are unvaccinated and who think that's okay. So if I were in crowded, I still wear a mask in public, in indoor situations. And I think that's perhaps over the top, but I do it anyway.
Yeah, and that goes to a question that we had from somebody that says, as school is starting back, and there are children who are not yet eligible for vaccination, what are your recommendations to ensure that the kids are as safe as possible? So it is to continue to wear a mask, to continue to social distance, to continue to wash your hands, and practice, the necessary precautions. Don't, if you're sick, stay home. If you're, all of those kinds of things. Any other thoughts or comments on that?
Yeah, also, so we put out a video a while ago with regards to ring vaccination, right? So the term ring vaccination refers to, people around a certain person. So say, for instance, there's a child and they're too young to be vaccinated at this point. Then you advocate for vaccination for everyone around them. So everyone in the household who's able to get vaccinated. And then, of course, paying attention to socially who they are in contact with, et cetera. Ring vaccination actually can be quite successful. It's been employed in the past for people with immunodeficiencies and things like that who are unable to be vaccinated. So besides all the social distancing and physical measures that have been suggested, ring vaccination is an important part of that equation as well.
And of course, schools should do their part, teachers should do their part, and letting parents know who has been sick when there has been an infectious exposure.
One other question that came in was talking specifically about masks. And do you have any recommendations as to which type of mask is the best to wear, like the disposable mask versus the cloth mask versus the ones with filters? Do you have any recommendations or thoughts about that? Or the most important thing is that you just have a mask on?
Yeah, I think that's probably the most important point is masking in itself, just with regards to, what you're trying to prevent obviously is droplet, transmission. So, yes, there are ones that are probably better in terms of filtering, et cetera, but in general, just advocating for masks in general, I think is an important thing to do and can be very protective and helpful.
And I totally agree on that. I mean, the major issue with masks is that if you have to wear that for a prolonged time, the issue is you have to wear them. If you wear an N95 for 10 hours a day, sometime I go to clinic, that's what I do, it kind of wears you off. And, and I'm a healthcare professional. Now, a child is a child. And, but, children, if they see their parents doing it, they do exactly the same. I have to say that, in some school in California, even in this past year, they had, decreased attendance in person, but in many schools, they didn't see any single case of child-to-child transmission as long as that every child was wearing a mask and they were observing social distancing. So I mean that social distancing and wearing masks is effective. We just have to do it. And again, the best thing to do is wear a mask. If you can wear one of the most filtrating one, great, but wear a mask.
Okay. One question off of the COVID conversation here is there's been a discussion on Facebook regarding aspirin being contraindicated with FAOD patients. Can you explain why that is and what it does to the body, and what would happen if an adult with FAOD did take aspirin? Or is that just a myth?
I haven't heard that. Now, the original cases of MCAD were mistaken for Reye syndrome. And we do know that taking aspirin with influenza in children can increase the incidence of Reye syndrome. And so I think maybe that's how people make that connection, but I'm unaware of recommending against aspirin. What are the other people? Nicola, Mark?
Yes, that's when Rye syndrome was a big deal in the late 1970s and 80s. It was a connection of aspirin and viruses. And of course, that's and the etiology or the cause was not known, but now we know that patients who got sick with Rye syndrome then actually had or likely had an underlying metabolic disorder, including fatty acid oxidation defects. So, of course, that's when acetaminophen became the drug of choice. My sense is to avoid it. I'm not sure we, from a scientifically, ever addressed the issue of aspirin specifically in fatty acid oxidation defects. So I think I would avoid it.
The good news, I haven't seen a case of Rye syndrome in the past 20 years. Meaning, I would say also that acetaminophen, yes, at very high doses can cause liver failure. A standard dosage and taken no more than 4 times a day is okay. I do like ibuprofen very much, better than acetaminophen, simply because it starts faster in terms of effect, and it lasts longer. Mean that people can eat, so can take ibuprofen at night, eat because they feel better, go to sleep, and then when they wake up, eat again. So which is exactly what we want to do in people with fatty acid oxidation disorder. That is the big advantage of using ibuprofen over acetaminophen. But again, a standard dosage, not giving that more than 4 times a day is okay. In the laboratory, many times we see the toxicity of acetaminophen. So in the urine organic acid, we see a compound which is called pyroglutamic acid that it is produced in excess when there is intoxication by acetaminophen. We still see that, but especially in adult individuals who have acute liver failure. We haven't seen that in fatty acid oxidation disorder. I mean, part of it is that with everything, with all of the information that people get, people know how to use this thing because the pediatrician, the metabolic physician usually stress out how to use it, when to use it, and what to look for.
Okay, great. Thank you for that answer, right? It's good to dispel the myths and the rumors, the old wives' tales, my mom would say. So the next question is, it's been mentioned that acylcarnitines can cause inflammation. Are there particular areas of the body that the inflammation is located, or is it just general and random?
I don't mean to describe it as an arthritis kind of inflammation. It's really more of a generalized internal in your cells. So one of the ways this was found was in evaluating patients with long-chain fat disorders. They actually just looked to see in the research laboratory what genes were turned on and what genes were not turned on in those patients when they were having an active episode. And it turned out that it was inflammation genes that were being turned on when the patients were having an active episode, which kind of led to this idea that perhaps inflammation is contributing, and for reasons we don't understand. So it's not like gout or arthritis where you're feeling it in a joint. It's kind of just an internal, generalized.
Yeah, I think that, the acylcarnitine is a reflection of what is going on inside tissue. We don't have much that we are measuring, but, the acylcarnitine is something that we can measure. We cannot measure the fatty acid that accumulate inside tissue. We are studying some classes of these fatty acids, which are called ceramides. Ceramides are involved in inflammation and also in opening and closing certain ion channels that are responsible for causing the electrical activity of the muscle and cardiac cell. So I think that the issue is really that the elevation of the acyl carnitine reflect the fact that something wrong is going on in tissue. Which tissue? Usually the tissues affected by fatty acid oxidation disorder. The liver, the muscle, the heart, and probably pretty much every other tissue as well. But but at the same time, those are the ones that we follow. It's not a generalized inflammation in the term of arthritis. It's not a generalized inflammation in terms of something else. It is something localized in the tissue that accumulate the fat.
Thank you for that, Dr. Longo.
I just want to make one comment about that, Kira.
Yeah, go ahead.
So what we've been talking about as far as inflammation goes, there've been some, markers done when kids are sick. We've looked at it when kids are well and there's not circulating inflammation in the blood. So I think that hypothesis that is still being explored. So I think we're a little early in being able to say exactly what the role of acyl carnitines are in inflammation. Would that be a fair statement? We're still trying to figure that out.
Yep, we all agree. Okay, great. Thanks. The next question is, for fat-soluble vitamins such as vitamin D, if the child is chronically low, is there a better way to try and improve these vitamin levels over another? Are there known absorption issues?
I can take that one. So if you have chronically low vitamin D, then I would probably recommend a multivitamin that contains vitamin D. I don't think high doses of vitamin D have in any way shown to be beneficial. So just a regular dose of vitamin D is appropriate. And I did a short study where we looked at patients who took their multivitamin at breakfast. Breakfast in a lot of patients with long chain FAODs tends to be a fat-free meal. So if you have fat-free cereal and fat-free milk and you take your multivitamin, it is less likely to be absorbed. And we saw low levels of vitamin E in particular when they took their multivitamin at breakfast. Fast forward, I had the parents switch and take the multivitamin at dinner because when you looked at the diet intake, there was more fat consumed at dinner. So they might have lean chicken and a vegetable. And so they moved that vitamin to a dinner meal where there was a little more fat in that food. And the plasma vitamin E came up very nicely. So I would recommend a multivitamin and consume it most likely with your dinner meal that typically contains more fat than breakfast.
Thank you, Dr. Gillingham. The next question that comes in is, we have always considered MCT and LCHAD to be somewhat unlimited. Is there any known issue with too much MCT or C7?
Okay, I'm going to get myself in trouble here, but I think the issue is we have so many calories, and if too much of the pie is coming from MCT or C7, it pushes out the other nutrients that you need for normal health and development. So you need a balance of carbohydrates, proteins we've talked a lot about, micronutrients, nutrient-dense foods that Mary and Sandy talk about. And if too much of your calories are coming from MCT, those are simply fat calories and don't contain other nutrients. So in my opinion, we need to keep the MCT balanced to provide the other nutrients that are required in our food.
And I agree. The major offender that we see all the time is simple sugar. When people get too much simple sugar, that it is the issue. So complex carb, pasta, tortilla, those whole grain bread, those are good things. Dessert, soda, juice, they're not great things. So basically, you need to maintain room for all of the nutrients that you need in your body and try to shy away from simple sugar. Keep in mind that this recommendation is not just for fatty acid oxidation disorder. It is for me, for everybody in this room, and for every normal individual. So following general nutrition guideline, to me, it is very important.
Thank you for that answer. So the next question, it's a really open-ended question, but I think it's something that a lot of our parents are struggling with is, can you talk a little bit about the impacts of puberty and a lot of families seeing increased metabolic issues as kids are transitioning into puberty. And what are some of the things that families might be able to look for, and things that are of concern, and how can they help maybe better, help their kids manage as they're going through puberty?
One of the things that I'll start with, and hope the providers can weigh in here, is we, at one of our GMDI conferences several years ago, Dr. Erin McLeod, who works out of Children's National, presented an abstract, and Dr. Gillingham, correct me if I'm wrong, was it on a CPT-2 patient who had a lot of incidents of rhabdomyolysis before the onset of her menstrual cycle. And then once sort of they figured out what was going on, the incidence of rhabdo really decreased after menstruation. So I think they're definitely, in females, we have to really look at what's going on with them, support them with calories and making sure their diet's good, and just making it known to the families and the patients that this is something that they need to be on the lookout for.
When patients are first diagnosed, then parents are taught what to look for, symptoms, signs they may notice. I think when puberty comes, you may have to do a relearning, because a patient's metabolic rate, metabolic demands changes, and symptoms may change, and it may take relearning. That actually is a lifelong process, because nothing remains the same from childhood to adulthood. So it takes relearning, and that's an important time.
Yeah, there have long been jokes about women, craving chocolate before their periods and whatever, but it does turn out that you are a little catabolic before your menstrual periods. And, finding ways to deal with that can help.
So the major problem I'm having with puberty is with CPT2 deficiency. One of the main reasons is that most fatty acid oxidation disorders are now diagnosed by newborn screening. CPT2 deficiency can typically be missed by newborn screening unless you have a severe form. What that means is that many times we diagnose children with CPT2 deficiency before or at time of puberty, which is a problem, because obviously that's when the learning starts, and some people, don't want to accept a lot of things. What happened in puberty? I mean, some of the more severe problem I had with some people who decided to lose weight and without any medical control. So and you see them in the hospital because, I had people going with a BMI that, it was like 25 to a BMI of 20. That it is a problem. So in other words, it can be done, but it needs to be done with supervision. And the biggest issue that I see in puberty is that they're on their own. Even if you talk to them, they don't listen to parents. They listen more to their peers. And I think that we still haven't found a way of telling them exactly what to do. I think that, what we have done with other metabolic disorder is having a group meeting where they meet together, they discuss what they do and how they do it. So in other words, they feel a sense of belonging there, and they listen to each other. In fatty acid oxidation disorder, especially in long-chain fatty acid oxidation disorder, is not that we have so many people, and I don't think we have been able to do a good job into doing this type of thing.
Yeah, well, hopefully we've kicked that off this weekend with our teen groups and our young adult groups, and we'll continue to provide opportunities for them to have these conversations and to share and talk about their experiences and to support one another. So we've got just a few minutes left for a couple more questions. We've had quite a few questions about statins. What alternatives to statins are available for FAOD patients with high cholesterol? Any takers?
I do not have enough experience with them in fatty acid oxidation disorder. In other people, I started using creatine a lot as a supplement, and that seems to help a little bit with the muscle problem. And it is believed that part of the action of statin that causes the rhabdo is due to the inhibition in the synthesis of creatine. It works a little bit in people who do not have fatty acid oxidation disorder, but I don't have any specific experience. I'm asking my colleague here if they have any of their patients on statin with fatty acid oxidation disorder.
I had one adult with CPT2 who was put on a statin in a research trial, but she did not tolerate it. It really exacerbated her myopathy. She didn't feel good on it, so they took her off. And they didn't try another drug. They just recommended diet and exercise, so more lifestyle changes. Just know that all the lifestyle changes that you can implement are not going to bring it down, 50%. It's going to have a 10 to 15% drop in total cholesterol with improvement in diet and exercise.
Okay, thank you guys so much. I appreciate you sitting in the, in the firing chair and letting us just throw these questions at you. I can't thank you all enough for how much time you've put into this weekend, preparing all of the information to share with our community. The feedback that we have received has just been tremendous, and I want you all to know how much this community appreciates everything you do to support our families and your tireless work, your research, everything that you do, your commitment, taking the calls after hours, Dr. Korson, taking those emergency room calls. We truly appreciate you and your commitment, and we're really, really grateful for all of you. So thank you for your time. Thank you for spending the weekend with us, and we will see you all very, very soon.
Thank you, Kyra. Thank you, Stephanie.
Thanks, everyone.